I'm Dr. Adams, and I'm a pediatric ophthalmologist in Albuquerque, and I want to do a brief video on visual fields. This is more geared towards medical students and, say, family practice residents or internal medicine residents, that sort of thing. So ophthalmologists obviously spend a lot of time with visual fields, and we get excited about them. I did this one today, and, for example, on the right side, it's normal, and on the left side there's this central scotoma. As ophthalmologists, we spend all sorts of time worrying about the decibels and the patterns and the pattern deviation and all kinds of things like that, which, frankly, your average medical student or family practitioner doesn't care about. For the neurologists or the neurology textbooks, you get this sort of thing, which is nice. I mean, you can learn where the lesion might be if it's related to the lateral geniculate nucleus, or if the posterior communicating artery may be a problem or something like that. You can show off to your friends and family. But frankly, this gets pretty complex. And if you're in the clinic or in the emergency room, it really doesn't help you that much. So I want to give some really simple basic rules, and there's really only two decisions that the average internist or family practitioner have to make when it comes to confrontational fields. Now, first of all, when you do a confrontational field, you will use yourself as sort of the control. So you close one eye, and if you're, so you'd be, with your right eye, you'd be looking obviously at the patient's left eye, and you can use your own visual field as sort of a limit, reasonable limit. You don't want to go out too far, but a reasonable limit about 3 feet away from the patient. You can present a couple of fingers, or, you can mix it up, maybe present 3 fingers in different quadrants. And I'll explain the quadrants in just a second. And then you can, do the other set of quadrants, that sort of thing. And you just get the patients to count the fingers. And then for the other eye, when I close my right eye, my left eye is looking at their right eye. And then I'll, do the same sort of thing on that. So to understand why we're checking each quadrant and what that means, I'm going to use some pictures over here. So to understand this, you have to understand first of all, how we document visual fields, and second of all, how the structure of the eye relates to what you obtain from a visual field. So we always draw the visual fields as if we are the patient and we're looking at the paper, okay? So the right eye is always going to go over here, and that's the oculodexter. And then the left eye goes over here, that's oculosinister, because apparently in the Renaissance, left-handed people were evil. So left was sinister and right was dexter. So anyway, the way the retina is oriented, there's the optic nerve, and then the blood vessels sort of course out from the optic nerve, and you have the fovea centralis, which is part of the macula lutea in the retina. And it's basically all oriented horizontally. So a cell that originates here is going to track back across to the optic nerve, and it's going to respect the horizontal midline. So you have the horizontal and the vertical midlines. And we always draw the horizontal and vertical midlines when we are drawing the visual fields, because those are the quadrants that we're testing with our confrontational visual fields with our fingers. So if you have a visual field defect due to damage to the optic nerve here, you're going to get a visual field defect that radiates out like that. If you have some problem in the retina here, you're going to have a visual field that radiates back like that towards the optic nerve. So this is going to be a visual field defect that respects the horizontal midline, but crosses the vertical midline. So you'll get a visual field defect kind of like this, or like this. Any of those defects, those people need to see an ophthalmologist. Okay? That's an ophtho-consult. Okay? So the next kind of visual field defect you can get is something at the chiasm. That's where the optic nerves meet and then split apart again. And that will give you a classic sort of bitemporal, or we call it heteronymous hemianopsia. So this is something where it crosses the horizontal midline, but respects the vertical midline, and it is basically out towards their ears on both sides. That's a classic for a chiasm. Those people need an MRI. And then there is anything else where it's basically on the same side. It can be quadrantic, or it can be, greater than quadrantic, but basically it respects the vertical midline and it crosses the horizontal midline and it's on the same relative side. We call this homogeneous. So it's to the right, say, visual field. In this particular drawing, it's in the right visual field, both nasally on the left eye and temporally on the right eye. And that is somewhere back in the brain, okay? I mean, it could be one of those lateral geniculate nucleus areas or the occipital lobe or the optic radiations. It really doesn't matter because, again, these people also get an MRI. So there's really only two decisions that you have to make. If it respects the horizontal midline but crosses the vertical midline, those people see an ophthalmologist. The gentleman that I showed the visual field from earlier, it was only in one eye, and it was cecocentral. So, and it actually was respecting the horizontal midline. And he obviously saw me because that was the appropriate thing. He had a problem in his eye. For the people whose visual field defects respects the vertical midline but crosses the horizontal, even if it's quadrantic, those people get an MRI. So really there's only two decision points to make with a visual field. Do they see an ophthalmologist or do they get an MRI? So I hope that simplifies visual fields from the neurology textbooks and from what ophthalmologists do, because when you're busy in a clinic and you're a family practitioner or you're in an emergency room, you don't really have time to go and think about your neurology textbooks. You just need to figure out where that patient needs to go next. Okay, have a wonderful day. Thanks. Bye.